but everybody is connected. But like I say, we do appreciate it's a really big issue, and we need to find ways to get beyond reactive good work, and looking at some of the fundamental reasons why this continues to happen. So just to reassure you that we are looking at that in some depth. So update, start with COVID, pandemic and vaccines. I had been trying to wean us off too much detail in these conversations following the really good progress of recent months, but I thought it would be useful just to update, given the national and local change of that situation, which has resulted in the delaying of the final bits of easing of the lockdown, which was due for the 21st, next week, as you're all aware. So unquestionably, the rates across the country have started to go up. The number of new cases is averaging about 7,000 a day, and it was down around 2, to give you some sense of scale. But it's nothing like as top of the peak of 100,000, over 100,000 a day at one point back in the winter. It's variable across the region. So the Northwest has been hit particularly badly, but good to report those rates are starting to tail off. We've had increased rates in the Midlands. The R value in the East Midlands is currently around about 1.1, 1.2, and it had been under 1 for some considerable time, and 1 is the cut-off. Admissions to a hospital had been increasing, but again, pleasing to say that in Nottingham, the admission numbers to Queen's City, Sherwood, or Queen's and City particularly, have started to reduce. And the other important piece of data around that is everybody that's been admitted has either not received vaccine or only received 1 dose. And it would seem that that backs up some of the national data that you require two doses to get the maximum benefit, but ever more so with this Delta Indian variant, which is the core. Something like 95% of cases are the Delta variant at the moment. So get the vaccine, get both doses, and that will give you the most protection. But the fact that the admissions are starting to fall is a good sign, and hopefully this delay to the ending of lockdown will be the final one. But for all sorts of reasons, the jury's out on that. To take us to vaccines, overall the system with well over 1 million. 58% of the local population have had 2 doses, and we're prioritising both second doses now, but also we'll be opening up at the end of this week to all 18 years and overs. From a trust perspective, we're still encouraging, urging, cajoling all our staff to avail themselves of the vaccine to best protection that you can have, but also to continue to use social distancing, proper and appropriate use of PPE, ventilation, etc. You'll have noted in the new national news overnight that it's going to be vaccination is going to be compulsory working in care homes for care home staff, following a consultation. And they've announced that there will be a similar consultation for whether that happens for NHS staff as well. Again, I suspect it'll be a similar 5-week period, after which the government and the Department of Health will take a decision as to whether to make it mandatory in healthcare settings. But as things stand, it isn't compulsory. We're encouraging people to do it. We've got lots of information about frequently asked questions, myth busting, and to encourage people to pick it up. So again, just to emphasise, if you think you missed your cohort date or it's too late, it's not. We're increasingly offering clinics, particularly at weekends, that no appointment is needed and could turn up and get jabbed. So we'd encourage people to do that. The final thing about delays to lockdown, for those, some people may have been involved in organising events post 21st of June, the original date, where larger numbers of people may have been congregating. If that's the case, just double check that, given that date's moved into July, that it's still permissible to go ahead, so we don't fall foul of any guidance or regulations. Then, in terms of non-COVID things, a hell of a lot going on as ever. Services across the organisation really busy. Demand is, you'll know, continues to increase, be massive. And that's not just in mental health, learning disability, community settings, forensic settings, and in the acute section, primary care too. So it's across the patch. People starting to access, and acuity levels are also quite high too. And I think our organisation is no different. People are exhausted. It's really important that you take leave. It's really important that if you're feeling you need some additional help and support, again, we've got a number of different avenues that you can connect to around health and well-being, to offer a variety of supports for people, because we do appreciate it's been a very, very tough year, but hopefully we started to develop an offer that can help people through tricky patches. And then finally, Alex, before I go back to you, just a couple of other things. We had a really successful Oscars ceremony last week. So there's some, hopefully some good footage, and just another acknowledgement of what a good thing it is to do, what fantastic work we get to hear about, and congratulations to all the people and teams that were nominated, shortlisted and winners. It's something that we'll be continuing to do. Hopefully, I know I said this last year, but the next one will be a proper event, but fingers crossed. And then finally, just to flag some of the things that you may see in some of the briefings and stuff, is we do a series of what we call chat pods, or I can never remember whether they're called chat pods or pod chats, but myself and Paul Devlin, the chair, will have a conversational piece around a particular topic. If people have something that they want to sort of publicise and have a conversation about. So we did one yesterday, for example, on progress on just and restorative cultures, and there were 5 or 6 of us having a conversation. It's recorded. It'll go on Connect and be available for people to watch. But you can imagine there's a whole range of different topics that we'd be more than happy to have a conversation about. So if you're interested in highlighting an area that you're working in, let us know. So that's updates from me to start off with. Alex, over to you for some Q&A, I think, unless there's any already come in.
Just to highlight, thanks ever so much, John. Tracy's put in the chat that we have an overview of the new Workforce Mental Health Hub on this week's Connecting Knots. So a bit of a plug for that. Thank you, Tracy. Oh, it's tomorrow at 2 o'clock, the next Connecting Knots. And as you say, Tracy's doing a piece tomorrow on the new Mental Health Hub, which is just a fantastic resource that's coming out for managers and staff about the new assessment and triage service. So thanks for that, Tracy. So we, as you say, John, we've had some questions sent in, and the first one is around admin. And the question is, do you think that there is merit in building an admin hierarchy which would support career progress, peer supervision and accountability? It goes on to state that admin staff are supervised by admin team leader, but admin team leaders are managed by clinicians. Would the management of admin benefit from a top-down admin approach rather than clinical approach? This would support them in working alongside clinicians, as sometimes admin can feel like an add-on to a service rather than an integral part of it. I could create a top to bottom admin structure to benefit everyone and build an admin career path. If you think this is merited, something I would like to be involved in.
So the short answer to that question is yes. It's something we had started to explore pre-pandemic, and then for various reasons slipped down the list of priorities. I think that the points are really well made. That admin can sometimes or often be thought of as an add-on or something that's easily removed as part of cost improvements, and for me it's the oil in the engine. Good admin is critical to the function of many individuals and many teams, and I think in terms of both individuals and for admin teams, the development, not necessarily a hierarchy, but a career structure that supports development, skill acquisition, management skills, leadership skills as a specific administration enterprise would be something that we'd be really supportive of. I think it's a really good suggestion. We've got an awful lot of really talented administrators right across the organisation. I think something that systematically and strategically put something like that in place would be, like I say, really welcome. So I don't know where that's from, but I'm sure there'd be some keen interest from various admin leads across the organisation to pull that together.
That's great. Thanks ever so much, John. Julie, just a question for you. Do we all have to order all new uniforms now?
That's a bit like all your family wanting a new wardrobe all at once, I think. I think it's great that we've got the uniform and it is available to order. I think the ideal is for lots of teams, when they're due to have a new uniform, is to obviously order the new one. If you are a service that's moving into a uniform and you haven't had one at all, and there's quite a large group of you, we just need to check that we've got some cash to pay for that. There isn't a magic uniform budget pot, a bit like in my house. There isn't a designer clothes pot either. So it's just about managing that, so that, you know, it'll take a few months to transition. But anything you order now, you know, to replace what you've got, that will be the way to go. But we didn't envisage reclothing all of the staff all at once. So John's smiling. I think he's trembling at the thought. But yeah, so yeah, as you go in terms of replacement, and if you're moving into uniform, we'll just check that we've got some funds for that. So it's a bit of a gradual migration, really. And then, you know, there'll be a point in time over the next few months when we're all where we need to be. So that's the plan.
That's great. Thanks ever so much, Julie. And just highlighting what Lynn's added to the chat, and thanks ever so much, Lynn Walker, for this. Similar to the chat pods, the Energy and Environment Department hosts a series of green pods. The next is tomorrow on National Clean Air Day, talking about air pollution and health. At 12:30, the link is available on Connect. That sounds fantastic. Excellent work. Thank you ever so much, Lynn, for highlighting that. The next question is around vaccines, John, and then come over to Linda as well. Do staff and the public get a choice about which vaccine they can have? We can see you, John, but I don't know if...
Yeah, so can you hear me now?
Yes, we can, thank you.
Now my screen started to freeze. So I couldn't unmute myself, but I think it's all coming back. Yeah, so this was a question I think Hanny, who I can see on the screen actually, asked the other week. Good to see you again, Hanny, about vaccine choice. Now, again, the simple answer is no, there isn't a choice of vaccines apart from some specified groups which are described by the Joint Committee under the license about. So, for example, if you're pregnant, if you're under 40, there are specific vaccines that you can have and that you can't have. In reality, the situation is a little bit more nuanced than that. So increasingly, most of our vaccine sites across the county increasingly have both vaccines, because there's been some change in the rules around the logistics of managing the ultra low temperature of the Pfizer vaccine, but some of that's been overcome. If you attend a centre, sometimes two different types are available. We have found, and we're not the only system that's found this, increasing amount of what's called AstraZeneca hesitancy due to the publicity around some of those clotting side effects a few months ago has put a lot of people off the AstraZeneca vaccine, which is, I think, really unfortunate. So from a personal perspective, so my view from a safety perspective is that the both vaccines are extraordinarily safe, and that clotting problem with the AstraZeneca one is actually less likely than getting a clotting problem as a result of COVID, which I think is a really important point. So within the system, we've got lots of AstraZeneca vaccine, but because of relative reluctance to take it up, but the supply of Pfizer is struggling to keep up with demand. So there's that tension, and as yet we haven't got any of the other alternatives. They will come online as the months pass. So that's the current situation. It might sound a bit vague, but technically there isn't a choice, but people can weigh up which vaccines are available at the sites they might attend. A couple of other things to say, and I don't know whether Linda might have some additional things to say about vaccine, is that at the moment the both doses should be the same. So if you've had a first dose of AstraZeneca, the second one must be that as well. There will be a programme of booster vaccines, so that will commence in the autumn. The high level plans on that are still yet to be confirmed as to whether it's 1 or 2 dose boosters. It's likely that the boosters will be a different vaccine to the one you had first. And there are also some trials going on to look at vaccine combinations, so people having both different types, to assess the impact on immune response. It's quite complicated. I don't know, Linda, whether there's more that you wanted to add about vaccines in general.
Yeah, I just wanted to say that with the encouragement for people to take up the vaccine, the hesitancy with AstraZeneca, increasingly a lot of the GP practices are supporting the myth busting. So people can actually request information and be given information to then be able to make an informed choice. I know certainly there's been various other groups that are promoting both vaccines, not just one, because previously there were issues around the Pfizer vaccine and some hesitancy around that. So we're now seeing it with AstraZeneca. So the best thing is to receive information and actually speaking to those people who have had COVID and really had severe symptoms. They will actually advise that you're more likely to have less serious side effects from the vaccine than what you would have as part of a COVID illness.
That's great. Thank you ever so much. Lynn Corcoran has asked, is the plan to continue to require and supply lateral flow testing for staff for the foreseeable future? Don't know who wants to take that.
Do you want to answer that, Linda, or do you want me to kick off?
Yeah, I can start and then you can add on. So currently with the guidance, even working with colleagues from across NHS England, we do need staff to continue with the lateral flow testing. We also know that these test kits have been extended to schools and other areas because it is really important if we're able to detect the prevalence of a virus in a particular area and also be able to protect those more vulnerable groups. So there's been no mention as yet of stepping down the lateral flow testing. If anything, we do need it because it's still there to protect ourselves and our loved ones.
That's great. Thank you. John, did you have anything to add?
Perfect answer.
Brilliant, thank you. We've had another question sent in, which is with the realisation that safe systems and processes are necessary to protect patients and staff from COVID-19, how as a trust can we best promote, support and embed a positive culture where staff see safety as the norm in their everyday working? John, are you able to?
Yeah, sorry, I wasn't quite paying attention there for 1 second, Alex. Is that on the thing?
No, it's been emailed into me. So I'll add it into the chat so that you can see it written down.
Would you mind just reading it out again so I could? Because
Yeah.
I was tuned into COVID and then it wasn't about that, was it?
Absolutely. So it's with the realisation that safe systems and processes are necessary to protect patients and staff from COVID-19, how as a trust can we best promote, support and embed a positive culture where staff see safety as the norm in their everyday working?
What a great question. So we might all want to have a little go at that. So my first attempt would be, yeah, it's a really good question, and I think as with most things in large in any organisation, any human organisation, getting the culture right and having the right values leads to the best outputs, whether you're looking at effectiveness of vaccines or safety for staff. I've just gone blank again. I don't know if you can hear me.
Yeah, we can hear you now. You keep coming and going, John.
I think I might have upset someone in IT and someone.
Julie, do you want to?
Oh. Have I gone?
No, you're back again.
Apologies about this, everybody. So I can't remember where I was. So yeah, so in terms of what for me the important thing is creating the right environments that supports the culture around what it is you're looking to address. We know, don't we, that in many of our environments, particularly clinical environments, that they're tricky and they're very high pressure, and safety is paramount, for both staff and service users alike. And where that's valued and respected, and we have the ability to have open conversations about when things don't go right and learn from it and develop the improvements, that's what makes the difference. and I think we're starting to do that. At different speeds to others, but I'm optimistic as ever that things are going in the right direction. I don't know whether Julie and Linda want to add something about that.
Yeah, I mean, I think it's a good question because it's the right question to be asking, particularly at the moment. I think there's a lot in it though, in terms of how you can shift your position, I think, as an organisation. I think there's something about the learning and, you know, things like designing out error in the things that we do. I think there's still a lot that we can do around some of that to improve safety. For me, there's always something fundamental about your underlying operating conditions. You know, are the basics there, whether that's, you know, the right staff with the right skills or the right environment or the right equipment, and how is all of that managed? There's always something about your underlying operating conditions and them being right. And I think through the last year, there's been something that shifted the underlying conditions. And that was some of the cultural things that John described about listening to staff, listening to what staff needed to, you know, keep themselves safe, keep patients safe, and ultimately deliver the best care possible. So I think there is something in that sort of cultural, if you like, category about how you do that really, and because that's, I think, what does make the massive difference. You know, it's not all about designing the right things, but it is certainly about listening to what's needed at the sharp end really, and responding to that. And I think that's something that the NHS has generally done really well. And I think we changed the shape of what we did, and some of that, in my view, we need to keep for the longer term.
That's great. Thank you ever so much, Julie. Mark.
Hello. I wonder if I might join the conversation, have a cheeky dig for research and evaluation. So I think it's a really good question. I think for me as a trust, safety is part of a triad of safety, quality and efficacy. And, you know, obviously for the best care for the patients, wherever possible, this culture as well needs to support good evidence-based care. So that involves research. So can we help you in any way to get involved or help you answer questions which you might have? So it's a dig, sorry, that's not the right word. It's a cheeky bid from research. But also, yes, I think it's part of a triad, so safety, efficacy and what have you. So let's be part of that cultural change.
That's fantastic. Thanks, Mark. Linda.
Thank you, Alex. I just wanted to add on to what Julie was saying around us as an organization and how we can shape things. We've already changed. I think what's important to note about safety as an organization is that our attitude has been really positive. So if you follow on from a really positive attitude, what you then do is every so often you revisit the issue. So us continuing to have those conversations to check where we are, to speak to our patients, do they feel safe? And us being able to then come back and evidence it in these platforms to say, this is what we're doing. So it's having that right attitude and continuing to be positive about it, and then being able to shout about it so that other people know and they are assured.
That's fantastic. Thank you ever so much. And just to add, Jane Bestwick has added drip feeders campaigns electronically in service areas and education enable and embed. And Ian Freegard has allowed me to let you know that it was his question. So so thanks ever so much for that, Ian. That's fantastic. Just moving up, Hanny has asked in the chat, and there are many available services for patients that can reduce the burden on our services and benefit patients. However, some of the staff are unaware of these services or sites, so patients do not get the best benefit of these services. How can we improve this knowledge, please?
So
John,
shall I start? And then I don't know whether Julie particularly might want to come in, but again, it's a great question. I'll come at it from a slightly different angle. Quite often get asked, what's the point of the ICS and ICPs and what does it all mean? One of the high level sort of priority objectives of developing the integrated care partnerships, the ICPs, sometimes referred to as PLACE, is to both reconnect services across different sectors, so primary care, GP, community, mental health, etc., but also tie them much more closely into their neighbourhoods and localities, because local people know what local services are available, particularly from the community and third sector and voluntary sector. And it's those sorts of services and organisations that can add a massive amount of both quality but resource input to many people that use our services that, as you rightly say, Hanny, staff working in big trusts might not be aware of. And relatively old-fashioned methods like keeping a directory in this digital age become so outdated so quickly. There's got to be other ways of doing it. So from my perspective, the development of primary care networks and integrated care in localities in the place will really start to help with some of these, because you're right, at the end of the day, not just in our teams, but the NHS is set up where it's relatively easy for many patients to end up at the most resource heavy, expensive end of the system without getting to inputs from some of the intermediary steps. So we've got too much flow into expensive services, and it's nowhere near as efficient as it can be. Julia, do you want to add something from your perspectives on that?
Yeah, I think Hanny probably knows some of what I'm going to say, but there's a bit more, I suppose. I think the range of things that are available to patients is only going to grow, particularly, for mental health. There's going to be a lot more mental health social prescribing. There's going to be a lot more sort of personalised support that's available that we don't provide. So I think it's actually becoming more important that we tie that all together. I'm placing a lot of stall on some of the things that are quite close to starting, which is for us it'll be a single point of access, but also some digital navigation. And I think if we can use those to the best advantage, they should help, well, hopefully both our patients and people supporting our patients to get the right level of resource and the right input. If we can manage those things properly, to make sure that they're not only about what our organisation does, but about the sort of broader levels of resource available. I think we might definitely get some of the way there, Hanny, because there is no point in having all these things available if nobody knows about them and the right people aren't accessing them. So I think it's an important part of the transformation, which it is actually going to be starting over the next few months. So I think it's our challenge to make sure that we look at that and it's broad enough, really, and it's not just about how somebody moves from a local mental health team to a community forensic team. It's got to be about access to all that broader level of support. So I think that's a space to watch, and I'm always pleased that Hanny sort of prods me, particularly with those questions that are going to make a difference over the next few months and years.
That's absolutely great. Thank you. That sounds really exciting and really good. I didn't know. And Hanny said thank you, John and Julie, in the chat. I mean, if you wanted to say anything, Hanny, please let me know as well. So
I'm just very passionate about this point, because when I first came to the UK, I went to the GMC to get a GMC number and said you can't get it unless you get a job. I went to the British Medical Association. I said I would like to get a job. They said, well, you can't get a job unless you get registration. These two largest organization couldn't tell me as a foreigner who came to the UK about what to do. So a friend of mine said, well, apply for a job by post. I did that on Thursday. I got a reply on Saturday. I started the job on Monday. And I think the patient is in the same position as I was many years ago, that there are many services around them. Something, for example, is like social services. You can actually self-refer to social services. I didn't realize that except many weeks ago. You can self-refer to occupational therapy. If you're in the city, you can self-refer to physiotherapy without going through to the GP. Now, if we don't know about these things, the patient doesn't get the benefit. And I think I'm very passionate about it. And there are so much information in the country and so much services, but not many people know about it. And I think in the last year, it has never been as good as it is now in available services for mental health patients. They can actually self-refer and contact and so on. So I'm very keen on getting things sorted in that particular aspect. There are hundreds and thousands of information, things like that, but we need to know the very basic that can actually benefit our patients. And the patient is exactly in the same situation that I was in many years ago. I'm very passionate about this point. Thank you.
Thank you very much. Your passion comes through, absolutely, and I love that example. The frustration, I just can't. Anyway. So, John, Julie, Linda, is there anything that you'd like to finish up with?
I can do a summary piece unless Julie or Linda want to add anything else. Julie.
Yeah, I was just going to let everybody know that the consultation or the public engagement process around Bassett Law, Bassett Law community mental health, and moving the possibility of moving the inpatient services has now concluded, and just to let people know that process is finished. There aren't any huge surprises in the feedback from the residents of Bassett Law about how they feel about the possibility of the inpatient services being moved, and sort of concerns about transport and travel, which we'll be working with the CCG to consider and hopefully address. So it's just really to update people and let them know that process is concluded, and we'll be doing some more comms about all of that next week. So it's just to give people a heads up that as we'd anticipated, that process is now concluded. So it's just to let people know.
That's great, thank you, Julie. John, did you want to?
Yeah, so start to sum up. So firstly to Hanny, thank you for persevering, Hanny, and I'm very glad you stayed and didn't get dissuaded and not stay in the country, because your contribution, I mean, I first met you in Leicester many years ago, has been immense. So thank you for tolerating some of our quirks. There's a comment from Jane Jane Bestwick in the chat, which is really to the point about we need to be better at showcasing what we do and share examples of best practice. Absolutely right, Jane. And we are starting to do that better. So one of the big functions, really important functions, is through our comms and engagement team. Now we're working with the multimedia team much more closely in terms of doing exactly that. I agree. I don't think we have been very good at showcasing so much brilliant work that goes on, often hiding our lights under a bushel, and we go to places and hear about things. Oh, I didn't know that, and oh, I didn't know we were leading nationally on this. So we need to blow our own trumpet a bit more. But Yolanda and the team are really starting to focus on that two-way engagement with services across the whole organisation to highlight where it's going well, and to share the love and share the learning, and bring the learning in to help us move forward. So that's a really good point. And then a couple of really important points to finish on. The first is, and don't close your ears or shut your eyes and pretend it's not happening, IG training. So by the end of this month, we need to be at 95%. If anybody's wants to proffer a guess as to what we are currently in the chat, there'll be a virtual prize for those that are closest, but we're not at 95%. And joking aside, it's really important national requirement for us to achieve that threshold. So there are 14 days to go. We'll be flagging with managers in teams where the rates are lower, so that you know that it needs to be done. We're making the accessibility simpler. We appreciate it's been difficult to find out exactly how to log on. It's electronic training, and there's a big button to press on the front page of Connect that says IG training, but it's also called digital security. It's the same thing. Getting in is still a little bit cumbersome, if I was honest, but the actual training itself doesn't take more than 10 to 15 minutes. So please, if you could take that on board, spread the word, and get the message to your teams. Those that haven't refreshed, please could they do that? And be greatly appreciated. And then finally, the other really important thing is just to let you know how badly I'm doing personally in the Euro 2020 football prediction scores. I submitted my flipping Excel spreadsheet with all of them on, and I'm 81st out of 85. I think there's some sort of fix going on, and given that I'm not very proficient at Excel spreadsheets, I couldn't possibly say what it is. But I did note that quite a lot of the procurement team were in the top 5. Just saying. Thank you very much for your contributions, for everything that you're doing. It's been a really good session. Remember, these are fortnightly. Everyone's welcome to Connect in Knots, which is tomorrow. Join in the conversation, and have a good afternoon, and see you all soon. Thanks very much, everybody.
Thank you.
Thanks, John.
Bye.
Thank you.